The following is our technique guide for in-office needle arthroscopy of the knee with lateral parapatellar retinacular release. Advantages include real-time dynamic assessment of patellofemoral tracking, reduced operating room utilization and avoidance of anesthesia complications, and a potential for true patient-physician shared decision-making, and a faster recovery. Potential disadvantages include a long learning curve with a wide-awake patient present and the utilization of a 0-degree scope. Relevant surface markings may include the patella, tibial tubercle, patella tendon, and the medial tibial plateau and lateral tibial plateau. The plant anterior medial and anterolateral portals are marked as above. In the office setting, a 25 gauge needle will be used to inject each portal site with 1% lidocaine in the interarticular space. Using an 11 blade, a 2 mm stab incision is made to accommodate the 1.9 mm 0-degree viewing needle scope. No capsulotomy is made to avoid extravasation, which can cause discomfort for the awake patient. A diagnostic arthroscopy is performed with the scope first inserted into the lateral viewing portal, viewing the medial gutter and medial compartment. The scope is then switched to the medial portal to view the lateral gutter and lateral compartment. Attention can then be turned to the notch which houses the intact cruciate ligaments. Attention is then focused to the patellofemoral joint to assess patellar tracking in the trochlear groove. Dynamic range of motion can be performed in the office to assess real-time patellar tracking. With the scope inserted into the anteromedial portal, the lateral parapatellar retinaculum is visualized. Using a 90-degree ablator, the deep layers are incised superior to inferior, beginning just inferior to the vastus lateralis muscle fibers. Layers are taken deep to superficial until the patella is tracking centrally within the trochlear groove. Ablation is conducted with caution, making sure not to violate the lateral knee capsule. The knee is taken through full range of motion to ensure appropriate tracking throughout. Pearls of the procedure include a comprehensive discussion with the patient regarding expectations for the procedure, as well as ensuring adequate local anesthetic. We recommend adding epinephrine in the saline for hemostasis and improved visualization. Pitfalls include poor patient selection, improper portal placement given the 0-degree needle scope, and inadequate visualization.